Hi, everyone, and welcome to our virtual health event with UC Health. My name is Hannah Parrott, and I'm the event coordinator here with the Highlands Ranch Community Association. We are so excited that you took the time out of your evenings to join us tonight to talk about stroke risk factors. We are grateful for UC Health Highlands Ranch Hospital as community partner and happy to host this wonderful event with their assistance. Before we get started, I would like to go over a few housekeeping items. During this webinar, your microphones will be muted. To ask questions, please type them into the Q&A chat box located in your control panel. This should be on the bottom of your screen. We will save the questions for the Q&A portion towards the end of this event. Our presenter this evening is Dr. Pope. And now, without further ado, I'll pass the time off to Dr. Pope.
Hello, everybody. Hopefully you can hear me okay. I'm Brandon Pope. I'll forward the slide here a little bit. Thanks for joining us. We're going to talk about a few different things tonight. We're going to focus on stroke in general, some basics about stroke, prevalence of stroke, and then we're going to move into stroke risk factors and how you can manage those risk factors. And we'll talk a little bit about the science behind stroke treatment and some of the newer therapies in stroke treatment, and then hopefully have time at the end for questions. So just so a little background about me, so you know who's talking to you tonight. Like I said, I'm Brandon Pope. I'm a neurologist. I practice primarily at Highlands Ranch Hospital. And we have our clinic at Sterling Ranch, UCHealth Sterling Ranch, which is about 10 minutes from Highlands Ranch Hospital. I kind of have multiple jobs within UC Health, but the two main jobs would be neuroscience chief and stroke director at the hospital itself, and then I also am the medical director of quality and safety at the hospital, and have a few other things that I do. So most of my time is spent in the hospital, and because of that, the majority of the time or a good portion of my time is spent seeing, treating, evaluating stroke patients. So let's get to the basics to begin with. What is a stroke exactly? We'll break this down into a couple of different main types of stroke, which are ischemic stroke, which is a lack of oxygen directly because a lack of oxygen brain tissue because of a blockage within one of the arteries, whether that's large or small. And then we have hemorrhagic stroke, which is which results in a similar type of injury, which is that there's not enough oxygen getting to the brain. But the main reason in that case is not because of a blockage, but because the artery itself tears, the blood escapes its normal pathway, it kind of gets out into the brain, kind of floats around in there. And so the normal oxygen delivery system is compromised and an area of brain could be damaged. But hemorrhagic stroke, and there's different types of hemorrhagic stroke, but generally speaking, because of the pressure of that blood escaping, it can cause other like collateral damage around the stroke itself. I'm going to go ahead and apologize right at the top. I've got a couple of emotional children in the house tonight. And so you may hear some of that in the background. So that's just the way it goes sometimes. So this is a question for the chat, and maybe we can throw a few of our answers in there, and you can report to me what was the most common answer here. But how many neurons die every minute during a stroke? Just take some guesses. I see D, A. I guess I can see it down here in the corner. A few votes for all of them. So C is the correct answer. 2 million neurons every minute. If you were to stretch 2 million neurons end over end, they would reach from Highlands Ranch Hospital all the way to the Denver Tech Center area. Around 7.5 miles worth of neurons, brain tissue every minute is lost during an acute stroke, and that equates to over an hour, the distance from Denver to Wichita, where I went to high school. And so, a little over 600 miles of brain tissue, which is lost every hour. So what is that, a little over 400 miles. So what does that equate to from a from the perspective of a normal healthy brain. So compared with a normal brain, this is a study in 2006 where they quantified what time as brain actually means. Compared with the normal rate of neuron loss, brain aging, the ischemic brain, or the brain that's not receiving enough oxygen, or the brain that's having a stroke, ages 3.6 years every hour in terms of overall brain neuron density loss. So it ends up being quite problematic, as you might imagine. There's lots of different symptoms, and we're going to get into some easy ways to screen yourself or a loved one for potentially having a stroke. But there's lots of different stroke symptoms. Here's some common ones, and it really depends on which part of the brain is being injured. So the anatomy is really important, and people like us, people like me, as a stroke neurologist, spend a lot of time and a lot of years learning the anatomy of the brain, in detail, so that we can recognize the various symptoms that can arise and sort of put these symptoms together, so we know when we see a patient, are they having a stroke or not. So, for instance, if you injure your middle cerebral artery, which are sort of the arteries that come out of the carotids and feed the left and the right part of the brain, you might have language, face, arm weakness. The anterior cerebrals, potentially leg or behavioral changes, impulsiveness, those sorts of things. If you were to injure the posterior cerebral artery, the PCA, you might lose vision in a field, either left or right, depending on which side. If you start to get your posterior circulation, the vertebral arteries, and up, you may have brainstem dysfunction, so double vision, trouble swallowing, trouble with mouth movements. If you get one of your cerebellar arteries like pica or aica, some of these small branches off of your posterior vertebral arteries, you might injure your cerebellum and get ataxia, which is trouble walking or discoordination. And then if you were to injure a small penetrating vessel or have an occlusion there, you might cut off supply to some of the long fiber tracts that control motor and sensory function. So you might get numbness and weakness. So these are sort of a general overview of common stroke symptoms. And as I mentioned, it really depends on which part of the brain was affected. So you can see some of those areas here in terms of, I don't know, can they see my mouse? Is that visible if I move my mouse around or no? Maybe not. The frontal lobe being some of that control, eye movement, motor, sensory here in the posterior relation, vision in the very back, and then we mentioned some of those other areas. So that's important to know. So how common is it to have a stroke? Well, it's actually really common. Starting at the age 25, 1 in 4 people in this country will experience a stroke, and a stroke occurs about every 40 seconds in the United States. Now, we're fortunate in Colorado to have a slightly, above average population in terms of overall health, but still common in Colorado. We see a lot of stroke patients here. So we talked about what are some signs of stroke before, but if you wanted to remember just a quick tool to screen yourself or a family member, if you think that, oh no, something changed, they're not quite right, what's going on? Whoops, went the wrong way. What we like to use is what we call Be Fast. So this might be something to take a picture of with your phone on the screen, and maybe print out or put on the refrigerator. But Be Fast, the B stands for balance. So difficulty walking, unable to walk straight, falling down, your eyes unable to focus. I would also throw double vision into that. The F is for face. So if you have a drooping smile or a drooping, one side of the face is drooping. The A is for arm. So if you get left or right arm weakness. S is for speech. So if your speech is slurred or jumbled, or I would add to that list, if you're having trouble producing speech, like you can't, the person seems like they can't find the word that they're trying to say, then T, time to call. And time to call 911 in reality, because as we'll get to here in a few minutes, the sooner that we get patients into the emergency room, the more options we have in terms of treatment and the more effective that those treatments are. So, if you think somebody's having a stroke, your best option is not to kind of wait and see or go to sleep. It'll probably be better in the morning, or, to potentially drive somebody in yourself. Just call an ambulance, they can evaluate for stroke symptoms in the field. They can alert us at the hospital that they think they've got a stroke patient coming in, and that expedites our process. So the faster, the better, and definitely going through 911 through EMS is the way to go if you think that you're having a stroke or somebody that you're with is having a stroke. So what are some risk factors? What increases your risk of having a stroke? So I broke this into two main categories. So medical risk factors are important, and then there's lifestyle risk factors. So let's go through the medical ones first. So having diabetes increases your risk for stroke, or having a fasting blood sugar greater than 100. Having high blood pressure or hypertension, specifically your resting pressure over 120 systolic over 80 diastolic. High cholesterol or hyperlipidemia, and specifically an LDL greater than 70 or a total cholesterol greater than 180. Being diagnosed with atrial fibrillation, which is an arrhythmia of the top chambers of the heart where they don't pump as efficiently and blood clots can form, is a very strong risk factor for stroke, and especially if untreated. All of these things would obviously be mitigated with treatment potentially if they were known about. And then having a family history of stroke. There are some genetic factors at play here, where even with good lifestyle and healthy diet and clean eating and all of that you're just going to have high cholesterol, and there's nothing that you can do about it through those means. And that type of high cholesterol, even though it's genetically based, would still increase your risk of having a stroke for yourself. And so, fortunately, medications can often overcome the genetics. And those people, it's sometimes a hard pill to swallow, because they're like, well, I exercise, my diet's great, blah, blah, blah. It's like, yes, but your LDL is still 140. That's high risk. You really need to do something about it. In terms of the lifestyle risk factors, so being overweight, which is defined generally as a BMI over 25. Now, BMI is definitely not a perfect measure, but that's a quick rule of thumb. Smoking, probably next to high blood pressure, is the most the riskiest thing that somebody can do in terms of long-term cardiovascular risk and stroke specifically. A diet that's high in saturated fats and trans fats. So think fats that are solid at room temperature, such as like butter, lard, those types of things, as opposed to more healthy fats that are polyunsaturated fats, things that are not solid at room temperature, that are liquid, like olive oil, avocado oil, those types of things. Simple sugars, so non-complex carbohydrates, simple carbohydrates, white sugar, table sugar, that kind of stuff. Too much salt, and then just generally excess calories. If you're in a calorie excess, just generally speaking, you're going to gain weight over time, and then your weight will start to be a risk factor. And then people who exercise less than 40 minutes around 3 to 4 days per week tend to have a higher risk of stroke in the long term. So here's a quick stroke risk quiz that we can go through. So let's take a minute just to do this. So you can just jot this down on paper if you have it, or try to keep track of it in your head. But basically, go through each one of these bullets. Is your blood pressure greater than 120 over 80? Do you have Afib? Is your fasting sugar greater than 100? If all of these, just down the list. If it's yes or unknown, give yourself a check in the higher risk mark. If it's no for sure, like it's not because it's been tested and you know about it, then put a check in the lower risk. And let's just take 60 seconds to run through this list, and then total up your scores at the bottom. Few more seconds here. Okay. Hopefully everybody's about done with that. If not, you can come back to it later. So the way this stroke risk quiz works is that, if your total score in the higher risk category was bigger than total score risk in the, or total in the lower risk column, then you have some elevated risk of stroke and ought to bring it up with your primary care doctor, go through these things, make sure that each one is being addressed if possible. Some of this is personal, smoking, family history you can't really control, but a number of these things are modifiable. And so if you answered yes or unknown to something that's modifiable on this list, that's something that you should definitely take to your doctor and start to talk about. So what can you do to protect yourself from smoking? We talked about a few things already, just as we went through the checklist there and some of the slides before that. But I would say a big thing is going to be diet. I have up here an image of sort of a traditional Mediterranean style diet, which is the type of diet that the AHA, ASA recommend primarily for cardiovascular health. And so what are you seeing here? You're seeing sort of a lack of red meat. That doesn't mean that you can't have any red meat, but it means that you ought to keep it to a minimum if possible because of the high saturated fat content. There are proteins here, like the salmon, for instance, which has healthier fats, polyunsaturated trans fats or non-trans fats, as well as omega-3s, DHE, DHA, all of those good compounds. You're seeing a lot of green, a lot of vegetables and fruits that are also green. You're seeing berries. You're seeing legumes, beans, seeds, nuts. Again, those seeds and nuts have a lot of those healthy fats, the kind of avoiding the unhealthy fats. What you don't see in this picture is a lot of dairy. What you don't see, again, is a lot of red meat. What you don't see is a lot of sugar. You may not see any sugar on this picture that's not contained in fruit as a whole food. And so just remember this snapshot, remember the colors, how colorful the food was, how everything was sort of fresh and unprocessed, lack of sugar. A diet like this is going to put you, definitely be a foot in the right direction in terms of long-term cardiovascular health. Exercise, we mentioned, really important. Not necessarily yoga, although this is a great picture. 30 to 40 minutes, 3 to 4 times a week is recommended. I would say if you can be active every day, that's great. So some sort of, a brisk walk with your significant other or by yourself or with your dog on most days, and then mixing in some sort of moderate to high intensity exercise 3 to 4 days a week. On top of that, it's going to help to keep your blood pressure in check, keep your body weight in check, reduce body fat, improve overall cardiovascular health and output. So really important. If you smoke, got to stop smoking. Like I said, next to uncontrolled high blood pressure, smoking probably next, if not, rivaling blood pressure at the top of the list of risk for having a stroke. You could do pretty much everything else right. And if you're still smoking, particularly cigarettes, you're going to be setting yourself up for potentially having a bad outcome. So smoking is really dangerous, really important not to do that. And then I would say having a relationship with a good primary care doctor who can help manage these risk factors to keep track of your blood work and your cholesterol, your blood pressure, medicate things that need to be medicated, coach on lifestyle, all of those sorts of things. I threw up a picture of our clinic here at Sterling Ranch. We actually share this space with primary care just down the road from Highlands Ranch Hospital. So it's one-stop shopping for you, I guess, if you need a primary care doctor and a neurologist. So there's a few of us there. But wherever you go, whoever your primary care doctor is, that's great. It's important to have a good relationship with those people. So as a summary and a couple other small tips here, fiber, we didn't mention fiber yet. I missed that. Getting around an additional 7 grams of fiber each day, which is not difficult, especially with supplements, helps to maintain healthy weight, helps to reduce buildup in vessel walls or atherosclerosis, which is high risk thing to have. Getting active, I mentioned the daily walking, which can be helpful in addition to your sort of moderate intensity exercise. We're going to keep saying stop smoking because it's very important. And then eating a smart diet rich in snacks like walnuts, avocados, omega-3s, salmon, tuna, fatty fish, things like that, avocados can really help. Another resource that I like to point people to is the free brain checkup that's available on healthybrains.org. This is a pretty cool website that was developed by the Cleveland Clinic. And you can take this checkup. It kind of goes through all of these different domains, which you see listed here on the diagram on the left. So, if you start at the top, obviously exercise, your diet, your overall health status, your sleep habits, and then those last two are how you stay sort of socially and cognitively engaged. Now, those two things, the social and cognitive engagement, may be less effect on stroke, but good for overall brain health and staving off things like dementia later in life. The first four that we mentioned, we've sort of been harping on already, with the exception of maybe sleep, which is important, very important for healthy, good sleep patterns, help with healthy cortisol levels, which are kind of stress hormone that in small doses in circumstances is probably good for us. But if those doses of cortisol in our blood are chronically elevated, it sort of puts us into a metabolic pattern that's unhealthy, cardiovascularly speaking. So good sleep, very important. And so feel free to go take this free brain checkup at some point and see how you do. It can give you some pointers of areas that you might want to work on. So far, what we've talked about is that stroke is very common in the US, very common, 1 in 4 after 25, if you remember, that time matters, that you lose many miles of brain tissue every minute that you're having a stroke without treatment. So what can we do? How can we, what are the treatment options? What can we do when we get into the hospital to help treat stroke? So we're going to pivot now at this point to talk a little bit about stroke treatment and some of the recent data around stroke treatment, some of the breakthroughs in stroke treatment that we've had recently. So many of you may know that, and as I mentioned, time is brain, so we're going to list in a timeline. Many of you may know that there are clot busting medications that exist, such as Alteplase or Activase, TPA, which we can give people if they come to the hospital fast enough and we recognize that they're having a stroke and they have certain, they lack certain contraindications, and they're within a narrow time window of less than 4.5 hours from their last known normal before the symptoms started, then they would be eligible, historically speaking, be eligible for that treatment. So that's great. That was a revolutionary 20 years ago, greater than 20 years ago, really, at this point. Late 90s is when those NINDS trials came out. And when the FDA approved Alteplase for the treatment of acute stroke within 3 hours, and then later it kind of got extended to 4.5 hours. But what else can we do? That's a pretty narrow window. Sometimes people wait because they're not sure, which I've already told you shouldn't do, but people do it anyway. It might surprise you. There's also people who, maybe in other parts of the country can't get to a hospital that quickly. So do we have other options outside of that 4.5 hour window? So that's what we're going to talk a little about today, because things have definitely changed in the last 10 years. So just kind of what we just talked about, stroke thrombolysis, the NINDS trials back in the mid 90s, TPA was approved for 0 to 3 hours. So that we had, but what about after the 4.5 hour window? So people have been trying to extend the timing for stroke treatment, TPA, device-based treatment for many, many years now. And we definitely had sort of a dark age of stroke treatment, like the renaissance hadn't come yet. We had sort of the TPA as the only option, and we were going through these dark ages of stroke treatment where it seemed like we would never get any new breakthroughs or advancement in those treatments. For example, there were studies in the late 90s, PROACT 1, PROACT 2, MERCI device in 2005, multi-MERCI, the interventional management of stroke 3 in 2013, Synthesis, Mr. Rescue. All of these were trials trying to either show that we could extend the TPA window by patient selection, or that we could use devices like this, like a corkscrew type device, to actually go up into the brain, into the artery, grab the clot, pull it out. Seemed like it should work, right? Like, there's a blockage there, when it started, you can get it, the clot comes out. But for all of these years, for almost 20 or 15 years, All of these trials were negative. That all changed in 2015 with Mr. Clean. So this was the beginning of the era, I should say, of stent retrievers or stent retrievers, which was a different technology, a different type of device. And Mr. Clean, published in the New England Journal of Medicine in 2015, showed that the number needed to treat for a positive outcome with this device, with this technology, was 3 to 4 patients, and the risk of intracranial hemorrhage or like bad outcome, bad complication was basically negligible. So this was a massive breakthrough in this era of stroke treatment. You can see some of their data here, and these were some of the other trials as compared to Mr. Clean. So all of a sudden, we had Mr. Clean as opposed to Extend-IA and SWIFT actually showing that relative risk reduction that we had not seen before. So everybody's excited. The absolute benefit of endovascular therapy compared with TPA alone was significantly better, ranged from 13 to 30 percentage points improvement depending on which study you looked at. As I said, led to a number needed to treat as low as 3 patients and no more than 7 patients in any of these trials. Just to put that in context for those of you who don't regularly read therapeutic journal articles, a number needed to treat in the single digits is like unheard of. We never get number needed to treat in the single digits. So this was excellent, and there were other trials that came out afterwards. For instance, the Dawn trial. We're going to replace that with this kind of Dawn because we seem to have a thing for household cleaning products. But Dawn showed the same thing. And so basically, now we had this new treatment, and some of these treatments were out to, wrong one. Some of these treatments we could extend all the way out to 24 hours. Whereas before it was 3.5 hours, like pretty narrow window, sometimes hard, even in a suburban or urban environment, to get a patient identified, transported to the hospital, seen, evaluated for stroke, scanned, and treated. Within 3.5 to 4 hours, 4.5 hours can be tough sometimes. So this was excellent, revolutionary for us. So let's do a quick case vignette just to kind of give an example of what a case like this might look like. So this is a patient who comes in with a last known unwell, which is uncertain. They were an inpatient. The nursing staff said that they had a normal neurological evaluation at around 8:30 a.m. This is a nursing staff at like an assisted living facility, for instance. EMS was called at 8:45, and at 8:50 they had arrived and diagnosed a stroke syndrome, called a pre-hospital stroke alert. So they call our ER at Highlands Ranch, say, hey, we've got this patient. We think they're having a stroke. We're bringing them to you. So we start to spin up our machinery. On arrival to the hospital, to Highlands Ranch, around 9:20, blood pressure pretty good, within range. Treatment is definitely viable. The stroke team is there at the bedside when the patient arrives because of that pre-hospital alert. So they already knew about it before the patient even got there. The patient has global aphasia, which means that they can't speak at all. They've got right-sided weakness and they're unable to blink to thread on the right, meaning it seems like there's not good vision on the right side, their whole right field. There's a little bit of droop on the arm. It's sort of withdrawing the pain and is looking off to the left. So they get what we do for all these patients, which is an NIH Stroke Scale. That's what NIHSS stands for, and it's an 18, which is pretty high. So this is a fairly classic syndrome of a left middle cerebral artery stroke with a high NIH Stroke Scale, with a good last known norm, or with a good time to arrival. We do a CT angiogram, and we see right where that red arrow is pointing that as compared to the opposite side, there's a whole big branch of artery missing on that image on the right, which is a conventional, or which is a CT angiogram. You can see that, and then there on the picture on the left, you can kind of see a bright spot there, which is dense blood clot that's sitting right in that artery. So we don't know for sure if they're a treatment candidate for TPA for alteplase because we didn't know their last known normal. So we take them to MRI, and what we see is that they have an area of injury definitely starting, but it's not completed on that side yet. So there's still viable tissue. There's viable tissue in that brain, in that area. So they get taken to, they're not eligible for alteplase because of that uncertain last time of onset, but they are, because we have good imaging to confirm their salvageable tissue, they are a candidate for recannulization via a stent retriever. So they go, one of our neurointerventionalists that we have at Highlands Ranch Hospital goes up into the brain with a catheter through the groin. They feed it up through the aorta, up into the neck and into the brain. They find the blood clot, they pull it out. You can see there on that picture on the right that all of that blood flow is restored, and the patient's stroke scale drops from 18 to 4. So a significant recovery in this patient. So now when we look at our timeline, we can see that there were definitely trials that we've seen now that have extended our time window out beyond, what we were able to do before, primarily with either imaging guidance, such as looking at that MRI to show that there's viable tissue there, and that plus the addition of thrombectomy, which at first extended it out to 16 hours with diffuse 3, but then like Dawn and Mr. Clean, as I mentioned, but Dawn specifically extended that time window all the way out to 24 hours. And there's a few other trials listed here. So then we got the wake up study. So this was a question saying, well, what if the patient wakes up from sleep? We don't know, grandma went to bed last night at 10 o'clock. She was fine. She woke up at 3 in the morning and was confused, and we checked on her and she wasn't moving her left side. So we don't know when it started, or maybe she woke up at 8 in the morning. So that, because that 3 would be kind of close. So let's say she wakes up at 8 in the morning. So we're if it started at 10:01 p.m. right after she went to sleep, she wouldn't be eligible for IV treatment because the time window would be too long. Well, if we take those people to MRI, we can look again to see if there's a mismatch. As you see those two pictures on the left, comparing the left to the right sequence, on the left, you can see that there's an area of brightness, that's a stroke, and the flare imaging on the right, which doesn't start to become positive in acute stroke until around 5 hours, is still negative. So that says, okay, yeah, that area of stroke it's happening, but it's not completed yet. We could probably fix that. Same on that middle picture as compared to the right picture where the flare is already positive. So that is not, that's not a patient that we would treat. So Wake Up had very positive results. Favored alteplase or treatment 53% over placebo, with a p-value of 0.02, which means it's statistically significant. And so this is another tool in our toolbox. So what we think happens is that when somebody starts to have a stroke, that their brain sort of activates them and wakes them up. And so these patients that wake up with stroke symptoms are potentially quite likely to have had a stroke that has started relatively recent from when they woke up, rather than like right after they went to sleep, for instance. So this is a tool in our toolbox. There was also the Extend trial. So this was looking at what if we find patients, or can we find patients that we could treat with IV treatment after 4.5 hours, within 4.5 to 9 hours. So to find these patients, this is a tool that we have at the hospital called, it's Perfusion Imaging. It uses AI technology to watch how blood enters and exits the brain, to decide if there are issues of relative ischemia, areas that are becoming injured but not yet dead, versus kind of core infarct areas that have already had a stroke. So this picture on your right would be an example of a report that I would get on my phone if a patient came into Highlands Ranch and was having stroke symptoms. And what you can see is that pink area is sort of our area, the core, the area that's probably already gone. But we've got this very large green area, which is sort of slow to fill with contrast, but still filling and still viable. And so if we see a mismatch like that and they meet certain criteria, then they can potentially receive thrombolytics through their IV out to 9 hours. And Extend also showed a significant positivity for stroke treatment or for thrombolytic treatment in those patients. And there's more and more trials coming out, specifically in the last 2 to 5 years, reinforcing this. And a lot of this is it's not yet in the American Heart Association guidelines, but it's in the Australian guidelines, it's in the European guidelines to a certain extent. So we expect to see these sort of extended TPA windows using artificial intelligence, perfusion imaging. We expect to see that become part of the US, the AHA guidelines, probably with the next revision. So getting close to the end here as far as my content, and then we're going to have plenty of time, it looks like, for questions. It's all about time. In order for us to get the best results for our patients, all of the diagnostics and therapies must be performed as quickly as possible, even if they have good imaging. So for instance, even in a patient like this who has good tissue, but this is at hour 7, if we have this patient in hour 2, then that pink area would probably be smaller. The green area may or may not be the same, but that core infarct starts to develop immediately from the onset of symptoms. So the faster we get people, the better they do in the long run. We utilize a stroke system at UCHealth. So patients present with stroke symptoms to, say, one of our freestanding EDs or like the urgent care at Sterling Ranch. We've got a very robust system to rapidly identify, transfer them to a more appropriate facility, place like our hospital that can give thrombolytics, that can do thrombectomies, that has ICU, with neuro capabilities and all of those sorts of things. And so we use mobile stroke units, which is the UCHealth stroke ambulance that drives, that responds to these pre-hospital stroke alerts. The mobile stroke unit can actually give thrombolytic treatment in the ambulance. So they actually get TPA before they even get to the hospital, which is a really good development. And they're talking about putting advanced vascular imaging in the ambulance so that we could even identify potentially a large vessel occlusion that might be candidate for a thrombectomy in the back of an ambulance. So when you come to the hospital, you're not coming to the ED to be seen and evaluated. We already know what's going on with you. You're going straight to the interventional lab, getting your clot pulled out of your brain so we can restore blood flow so that you can have one of those dramatic outcomes. And then tenecteplase is a new, it's not new, but it's an alternative TPA from the alteplase that I expect will be rolled out to many systems, including ours, before the end of next year. And it offers probably better outcomes from a thrombolytic perspective than alteplase. It's probably safer. It's also got some logistical and workflow benefits, but from a patient perspective, it's likely a superior. We know it's not inferior based on the trials that have been done so far, but it may actually be a superior treatment option. So tenecteplase may be the new treatment if you come to a UCHealth hospital, in addition to the thrombectomy and all those other more advanced things. So last thing I'll say as part of my initial part here is remember to be fast, to know the signs of stroke, to know the symptoms. And if you see something like this or something that we mentioned earlier in the presentation, don't wait around, don't wait and see. Just call 911, come into the hospital, let somebody like me or one of my colleagues look at you in person, or virtually in some cases, and evaluate you and help you to make a decision about treatment. That's one of the mobile stroke units, just to kind of show it off. And in the back of that ambulance, they have a CT scanner and TPA. So if you get evaluated, if the mobile stroke ambulance responds to an EMS call that the EMS thinks as from the call might be a stroke, they can dispatch, I should say, the mobile stroke unit. That unit comes to your house, they put you in it, they scan your head. The stroke neurologist gets on a camera and screen and talks to you and does the NIH exam. And if there are no reasons not to treat and you look like you're having a stroke and your CT scan is negative for bleeding, then they can give you the lytics right then and there. And then they bring you to the hospital so you can have further monitoring and testing. So pretty cool stuff that we do around stroke treatment these days. And it seems like, unlike the dark ages of the late 90s and early 2000s, where we finally broken through and we're getting new therapies and new options for patients. So we're really excited about the future of stroke care. Any questions? I think that's my last slide. What questions came through the chat?
Great. Yeah, so we do have a few questions, and just a reminder, if you do have questions, please type them into the Q&A chat located in your chat box and control panel. So the first question we have is, after a cerebellum stroke, how long can balance issues continue?
So I would say, just to make it a broader answer, after any stroke, the symptoms can be lifelong. But they're usually not, at least not as severe as they are when the stroke first starts. So strokes are always the worst right at the beginning. They come on within a few seconds to minutes, and they're usually at their sort of peak, unless there's something weird going on, at their peak right at that time. And then, what treatments are given makes a difference in terms of how much recovery somebody would have. And then ultimately, it's time. We unfortunately don't have a way to help brain tissue heal directly. What we can do is intensive therapy, physical, occupational, speech language therapy. We can manage risk factors to reduce the risk of another injury. And then the brain sort of has to heal itself over time. Brains are better at healing the younger they are, the healthier that they are, but even in later years, people's brains can really heal very well. We typically expect most of the recovery of symptoms to have occurred by the 12-month mark or so. That's not a 100% rule. Definitely the trajectory of the healing process makes a difference. So if by week 1 you're already 50% better, then that's a pretty good sign that you're going to continue to improve at a fairly good rate, maybe back to normal. Whereas if it's been more of a slow process, then you may not have complete recovery.
Great, thank you. And next question is, does having one or more stents increase or decrease your risk of stroke?
One or more stents. I assume that they're talking about like stents in the neck, like if you have carotid stenosis or something like that, or they might be talking about coronary stents from a heart attack. The answer is sort of the same in both. I'd say if you're needing multiple stents, it's probably because you have fairly poor vasculature with a lot of atherosclerosis and like narrowing and those sorts of things. So somebody like that, who's like a vasculopath, is definitely more likely to have strokes in their lifetime. But the stent itself is not really much of a risk factor for stroke, as long as you take the appropriate medications to prevent clotting within the stent, which tends to be antiplatelet medicines like aspirin or Plavix or both. And the timing of that varies depending on the type of stent and all that kind of stuff. But as long as you're managing the stent the way you've been instructed to, the stent itself is not really a risk. But like it's somebody who has lots of stents means they probably have lots of bad blood vessels.
Okay, great. Next question is, how often after you have a stroke should you get checked up by your neurologist?
So we try to get people in within 2 to 3 weeks if possible. Usually that's not because there's something super urgent that needs to happen with the neurologist. Most of the workup, the plan, the medication plan, the therapy plan is all sort of established in the hospital. But we still think it's a good idea to see those patients because, plans can be confusing and maybe referrals fall through the cracks, and we don't want to have delays in therapy. So, in our group, we try to get people in at like that 2, 3, at the latest 4-week mark to make sure all that stuff is in order. And we always usually recommend that the patient sees their primary care doctor because they can also help with a lot of that stuff, within a week or 2 at the most after discharge from the hospital.
Okay, great. And next question is, what is your opinion on fish oil supplements?
I think that the data for fish oil supplements in terms of stroke prevention specifically is not super robust. It definitely helps to raise good cholesterol. if you don't get a bunch of that through your diet, like you're not a big fish person, or you don't like avocados, like the stuff where you can get that naturally, then it is a way to kind of offset that from a diet perspective, which makes a difference. I personally take fish oil, not that that necessarily means anything to you all, but so I don't like push it necessarily, but I never have a problem if somebody wants to take it because they feel like they need to supplement their diet.
Okay, great. Next question is, if there's a person who has smoked for 30 years, but now no longer smokes and has lost weight significantly and has good blood pressure, is the damage already done? And for this person, they have a history of stroke, which is still a high risk, or is that not a high risk?
So yeah, so the way I would think about that is that if you're smoking, your risk just climbs and climbs and climbs and climbs like over your lifetime. If you stop smoking, it doesn't like plateau there. It actually does decline a little bit, but it might not get all the way back down to where it was had you never smoked, because there can be like accelerated atherosclerosis buildup and those sorts of things that are hard to reverse. Now, if it's significant in certain areas, they can stent it and things like that. But yeah, I would say that it definitely, like, stopping is not just like, okay, my risk was 0 not smoking and it got all the way up to 90 because I smoked for 30 years and I'm going to stop smoking and now I have to live with the risk of 90 for the rest of my life. No, it might like come down to like 60 or 55 or something like that. So it's definitely has long-term effects regardless of if you stop. But then the other way to think about it is that if you keep smoking, that risk just continues to accelerate. So it's going to, even if it did just plateau, that's still better than letting it just keep going, where you're like ultimately going to have a stroke and there's nothing that you could do about it.
Okay, great, thank you. And the next question is, are there imaging tests that can assess for stroke risk in people with a family history?
Not well. I guess one thing that could be done is angiography of the head and neck. So looking at the blood vessels to see if you've got, or sometimes they'll do that with carotid ultrasound, just to look at the carotid arteries. A lot of times people who have a strong family history of stroke have family members like high cholesterol, hyperlipidemia, hypertension, those things run in their family too. And so you may be more likely at a younger age or what have you to have developed those things. So screening for carotid stenosis, which is a high risk lesion for eventually having a stroke, is possible. It could be helpful and meaningful, especially if you're not being treated or you didn't know about it. But in terms of like imaging of the brain itself, there's really not a one-to-one correlation with things that we see on the brain. Now, I will say that on brain MRIs, sometimes we will see patients that have prior strokes that they didn't know about, and that kind of automatically statistically puts them in a different risk category. Or they'll have lots of what we call microvascular or ischemic changes in their brain, which shows that maybe they haven't had an outright stroke, but they've had, like, you can tell that the small vessels in their brain are not super healthy. We don't typically do scans like that just for no reason, like, or for screening because of family history. We often find those things incidentally if a patient gets an MRI for another reason or something like that.
Great, thank you. And next question is CAA a type of stroke, a condition that causes stroke, or totally unrelated to stroke?
That's a really good question. CAA is a condition that leads to stroke, particularly hemorrhagic stroke. And so that's cerebral amyloid angiopathy. That is a disease that leads to amyloid protein deposits forming around blood vessels, which makes them weaker and more likely to break and bleed. So patients with CAA over the course of their lifetime, it's pretty rare, but patients with CAA over the course of their lifetime definitely have an increased risk of stroke, particularly hemorrhagic stroke. They shouldn't take blood thinners. They shouldn't take antiplatelet medications like aspirin because that increases their risk. As with most things related to amyloid proteins, such as like Alzheimer's disease, for instance, there's not a lot we can do about CAA in terms of like treating the underlying condition. We just have to try to manage the risk.
Okay, great, thank you. The next question is, my dad had a 98% blocked carotid arteries at 65 years old and experienced a stroke after they did surgery to unblock one of them. He was a heavy smoker for the first 30 years of his life, but otherwise has had no health issues. Am I at a higher risk because of this, or was the smoking most likely the cause of his problems?
Probably personally I would guess you might be at a slightly higher risk, just because, to get 98%, I mean, I don't know for sure, but that's pretty extensive for just being related to smoking, but not impossible. It could be that it was a combination of smoking plus some genetics around lipids and cholesterol. So I would say, obviously don't smoke. You know that already. I would say, make sure that you're having your cholesterol numbers checked frequently, at least yearly, to make sure that that's all in check. And then, like we mentioned in a couple of questions before, you could potentially get your carotid artery screened. I think if you came into your primary and said you've got a family history of a critical stenosis in the carotid at a fairly young age, that would be enough to warrant taking a look at yours and just making sure that you're not also developing like early carotid atherosclerosis and stenosis, because that is a pretty high risk lesion. Even if you don't get it corrected, getting it corrected is definitely the right thing to do when it's 98%. Unfortunately, sometimes in the course of those, there are strokes, big and small, that can happen. So that's a kind of a known unfortunate adverse event related to carotid endarterectomies, which is where they go and surgically cut it out, versus sometimes we do carotid stenting, where they'll put a stent in intravascularly and open it up.
Great, thank you. The next question we have is, what are your thoughts on giving aspirin to an individual when you think they're experiencing a stroke?
I think that it's probably helpful, unless they have a reason not to take aspirin. It's not a replacement for TPA or other more advanced treatments that we do in the hospital, but I don't think it's going to hurt anything. And if there is, so aspirin's an antiplatelet medication. It helps to keep platelets from glomming onto each other and forming clots. So if that's not always the reason why somebody's having a stroke, but if that is part of the reason why somebody's having a stroke, then it could be helpful. Typically at more full dose aspirin, like 325, not the 81 milligram baby aspirin. And if somebody's having a hemorrhagic stroke, and you don't know that yet, obviously, if you're doing this at home, getting a dose of aspirin is unlikely to make like a significant difference. It's still pretty common practice for emergency crews to give aspirin to patients who they think might be having a stroke, and I typically don't have a problem with that.
Great, thank you. And next question is it possible you've had a stroke or TIA despite having a normal CT or MRI?
Yes, to both. The TIAs should have normal imaging. So transient ischemic attack is a brief stroke-like event where whatever the problem was, whether it was a little blood clot or a spasm of the vessel or something, resolves itself before any tissue is damaged permanently. And so MRI, CT scan should be negative. In stroke, an actual stroke where there is injury to the brain, it's much less likely for the MRI. CT can be negative, especially if it's small or early. It's very unlikely for the MRI to be negative in those cases, but it does happen occasionally if it's a very small stroke. MRIs are good, but they're not perfect. And a stroke, tiny stroke can sort of slip between slices on the scan. So I have that happen, handful of times a year, maybe less than that. I can only think of one recently that I was pretty convinced that they had had a small stroke, but their scan was negative.
Awesome, thank you. And next question I have is, I have Afib and I'm taking medication to regulate my heartbeat. Does this reduce the chance of stroke?
That's kind of a hard question. If you're taking medication that is an antiarrhythmic that keeps you from being an AFib, which is less common, then that could potentially protect you from stroke. If you're taking medication to control your heart rate, like a beta blocker, which is pretty common in AFib, then that would help control your heart rate, but it would not protect you from a stroke or a clot forming because of AFib. And then in those patients who have AFib, who are in it some or most of the time, really should either be on aspirin or a full blood thinner. And the difference kind of depends on your risk factors. There's calculators out there to help decide who should be on full strength anticoagulation versus just baby aspirin. But I would say, generally speaking, rhythm control or rate control, alone doesn't protect you from the stroke risk.
Great, thank you. And next question we have is, what's the difference between a stroke and a TPA?
So I'm guessing you probably mean a stroke or a TIA. And a TIA, I mentioned a second ago, is called a transient ischemic attack. So it's like a stroke in terms of the symptoms. They can look identical, but they're short-lived episodes and they kind of resolve spontaneously. So like if there was a blood clot in an artery, it like breaks apart or the body kind of dissolves it. Or if a vessel spasmed, it opens up, or its neighbors sort of like took over for blood supply. And ultimately in TIAs, there's no permanent brain injury or area of ischemic or stroke on the MRI. And TIAs should be fairly short. Technically, up to 24 hours is what the definition is, but typically TIAs are like a few minutes at the most.
Great, thank you. And just two more questions. Can DVT lead to stroke? If so, how common or rare is that?
DVTs can definitely lead to stroke. The problem with these are all really good questions. You guys have just really good questions. DVTs, or deep vein thrombosis, is a blood clot in the veins, not in the arteries. So we talked about how the arteries are what feeds blood to the brain. So for a DVT, a clot in the vein, to cause a stroke, it has to find its way into an artery. Typically what happens is that, so if you imagine the sort of cardiovascular system, your veins all lead into a couple of big veins and they go into the right side of your heart. And that right side pumps them into the lungs, because this is coming from the veins, so it doesn't have oxygen. It goes to the lungs to get oxygen. Then it gets pumped into the left side and that gets squeezed out into the rest of your body. So most DVTs, if they travel, will go to the lung, which is a pulmonary embolism, which can be dangerous and sometimes it's not a big deal. If they're big, they're bad. About a quarter of the population has a little hole, or sometimes a big hole, in the atrium, in the wall between the right and the left side. And if that's the case, then a blood clot could come up to the right atrium and actually pop across to the left side, bypass the lungs, and then have free access to the arterial system. Doesn't mean it would necessarily go to the brain. It could go anywhere, spleen, liver, whatever. But definitely could go to the brain. So, those holes are so common because when we're developing in utero, our blood coming from the veins is actually already got oxygen because it came from the placenta. So it doesn't need to go to the lungs. So there's a hole there on purpose to let the blood cross the barrier and go to the body. When we are born and we breathe, that little hole shuts, the pressure changes, the little flap shuts, but in a lot of people, it doesn't shut like 100%. So anybody who has a stroke, pretty much anybody who has a stroke, we screen for that problem to make sure they don't have a hole there. How big is it? Does it let stuff through? And then we might screen like their arms and legs for clots and that sort of thing. That was a long answer to the question, but yes, the answer is yes.
Great, thank you. And last question. Can having treated or untreated sleep apnea or restless leg syndrome increase your risk of stroke?
For restless leg syndrome, I would say no. Restless leg syndrome can sometimes be an indication that somebody is anemic, and also has some other potential long-term complications, but I wouldn't put stroke on that list. Sleep apnea, I would say yes. And the reason for that is because chronic sleep deprivation, which is ultimately what sleep apnea causes, leads to that increased sort of inflammatory cortisol-driven stress state. which is bad for cardiovascular health. It accelerates atherosclerosis and it raises blood pressure and all those sorts of things. It's also really bad on your lungs, can cause pulmonary hypertension, which can cause heart failure. Heart failure can lead to stroke. So sleep apnea is, especially in this country, because we have such a problem with sleep apnea in this country, is a really big misunderstood and like undertreated condition that has a lot of really bad long-term health consequences. And I would put, if it's untreated, and I would put a stroke on that list for sure.
Great, thank you. Well, we just want to thank you all for attending our UC Health evening. Thanks for UC Health to Dr. Pope. We will be sending out a recording of this webinar within the next day or two for those who asked. And thank you for joining. Our next virtual health event won't be until September. So please keep an eye out for that information that will start to come out in August. Thank you for joining us and have a great rest of your night.
Thanks, everyone. Bye.